Thank you for the invitation to present our project here in this setting at this nice conference. So what I am working on is basically trying to develop a new platform, which is an in vitro platform for drug screening for respiratory viruses. So why are we interested in this? Of course, you all know that basically the respiratory tract is exposed to inhaled particles, which also includes viruses. So there are several circulating viruses that are normally there, and still they can infect actually all anatomical site of the respiratory tract. However, the most severe disease or fatality rate is observed in lower respiratory infections, and it is still among the top 5 causes of death globally per year. So the last event actually that happened and also threatened the public health was actually the emergence of a SARS-CoV-2 virus, which I think by now you all know is a coronavirus, and it has these typical spike proteins on the surface, which bind to the host cell. The receptor for SARS-CoV-2 is AC2, and the processing by TMPRSS2 basically allows the virus to enter the cell and infect the cells. So also this virus, it can manifest in all sides of the respiratory tract. In the upper airways, it can infect mainly the ciliated cells or also secretory cells, but the symptoms are usually mild, despite high viral titers that are reached in this area of the lung, of the respiratory tract. However, severe manifestation is observed once the virus reaches the alveoli and the distal lung, where the primary target cell are the AT2 cells, which then leads to massive inflammation and microvasculature activation, and finally also to the breakdown of the air-blood barrier. And diffuse alveolar damage is a common pathological manifestation that is observed in the lung of diseased COVID-19 patients. So there is a lot of progress that has been made since the emergence of SARS-CoV-2, but there is still limited knowledge about the mechanisms of COVID-19 and infection into the cells, and also we have limited possibilities to screen novel drugs. And therefore, this is mainly due to the limited or to the extreme difficulty to model the alveoli in vitro. So currently, a lot of studies are still working with animal models, and in the context of COVID-19, they are also suitable to some extent, so they can recapitulate the full complexity, and they also develop COVID-like symptoms, such as age correlation with disease severity. And of course, then we also have the systemic response that is best to be modeled in animal models. But the limitations, particularly with COVID-19, is the species tropism for SARS-CoV-2. So basically, for example, mice are not a natural host of this virus. And also the anatomical and immunological interspecies differences that we have between the animal model and the human patients. And also usually the animal models that we have for the infection develop less severe disease and usually spontaneously recover, which does not recapitulate the severe progression of severe COVID-19 that we see in some patients. So therefore, there's actually the aspects that could be better modeled in vitro models that are human-derived. And there are currently advanced in vitro models at our hand, which provide also 3D complexity, such as the organoids, the 3D in vitro tissues, and lung-on-chip models. And we actually plan to use these 3 in vitro models to develop Alvirix, which is this drug screening platform for respiratory viruses that I mentioned before. So basically what we would plan to do is to develop a medium throughput in vitro model, which mainly will be organoids or transwell inserts, to pre-test some compounds and then only validate the most promising candidate compounds on the most complex in vitro model that we have, which is the lung-on-chip model. So starting to derive the organoids, which was the first step of this project, because we have a source of a very high quality primary alveolar epithelial cells, And we started to optimize organoid culture conditions for this cell type. So we isolate them from the alveoli of donors. And as you can see, putting them into culture, basically they start to form organoid structures within a few days. And we also saw that they express typical type 1 and type 2 alveolar epithelial cell markers. And also looking at some additional 81 and 82 cell markers and comparing them to the starting material, but also to primary alveolar epithelial cells that are cultured on conventional transwell inserts. We actually saw that the organoids were quite well in preserving the alveolar epithelial cell characteristic. So basically, it was notable that especially the 82 cell character was much better maintained in the organoids upon 2 weeks in culture compared to the transwell inserts. And also at the next step, we also had a look at the host factors that are required for virus infection of these cells. So we also found that ACE2 and TMPRSS2 is expressed in our organoids at a lower level than with the starting material, but still we could detect in all the donors these 2 host factors. So to summarize quickly, the advantages in our organoids so far is basically that we have alveolar subpopulations or subpopulations of alveolar cells that form heterogeneous organoids. And also we have an enhanced preservation of 82 cell character in our organoid cultures compared to transwell culture. And also they express relevant markers for disease models. So in my case, this would be for COVID-19 models. We did not yet progress to infection protocols since this is very precious material. But as a next step, of course, we would like to work on the upscaling of our culture method for the organoids, that we can use them for toxicity pre-screens. And also then afterwards, we would like to try to infect them, that we can also apply them for efficacy screens and actually treat them with drugs. And of course, they're also a very nice tool because they improve the handling and the storage and expansion of primary alveolar epithelial cells, which currently is still a limiting factor to use these cells in vitro. So then I would actually like to switch a bit to the monolayer models, which are the lung-on-chip and the transwell models. And here, as I mentioned before, we have not yet used the primary cells because it's very precious material. So we use as an alternative cell line models. And we would like to actually develop these models for the different anatomical sites of the respiratory tract. So for the upper airways, we use the BCI NS 1.1 cells, which have been originally derived from basal cells of bronchial brushes. Then we have a model for the small airways. We use the CALU3 cells, which are a very nice model or a very standard model also in SARS-CoV-2 research. And for the alveoli, we are using an in-house generated alveolar epithelial cell line. So for this talk, I would like to focus on the lower airway models, so basically on the CALU3 cells and on our alveolar epithelial cell model that we have here. So starting with the development of the medium throughput in vitro models, basically the transwell insert cultures, we had first a look at the CALU3 cells, and you can see as a first experiment, we actually checked if the submerged culture or the Ali culture is better, or if we should really go into Ali culture or not. And what we see actually here is that already the CALU3 cells express higher levels of the AC2 and TMPRSS2 in a lipid interface culture, also highlighting the importance of Ali culture for the lungs. However, when we infected these cells, we did not notice a difference in the infection rate between submerged culture and the liquid interface culture for the CALU3 cells. And also, when we looked for the virus production, basically these cells are very susceptible to SARS-CoV-2, and we got a very high virus titer already after 24 hours of infection in both conditions. And this coincided also with the breakdown of the barrier, so we really observed cell death, and this of course led to the breakdown of the barrier. Then next we asked ourselves if we can transfer or just translate this protocol that we have for the callus-free cells to the alveolar model in the transvels. So this is basically, as I mentioned, we are using these alveolar epithelial cells that are in-house generated. So they are derived from primary alveolar epithelial cells and have been immortalized. And they contain a mixture of 81 and 82 cells. And we have also optimized them for on-chip application. As you can see, they maintain a high barrier function over extended culture in submerged and in a liquid interface culture. So I will not go into more detail into characterization, but my colleague has a poster as well if you are interested to pass by. So we also checked for the expression of host factors of SARS-CoV-2, and we found actually that they express AC2 and trimpresses 2, and also similar as in the callus-free cells, we see that these host factors are higher expressed in a liquid interface culture as compared to submerged culture. So then we also infected them in a similar setup as before, comparing submerged culture to a liquid interface culture. And what we see here really strikingly is that in submerged culture, we have only very few cells that are infected with the SARS-CoV-2 virus, whereas in a liquid interface culture, we have cells that are infected already at 24 hours, reaching a peak at 48 hours post-infection, where almost 40% of the culture are infected by the virus. And then somehow these cells get rid of the virus after an additional 24 hours. When we look at the virus production, then we really see that the liquid interface culture is the only method that was able to produce high viral titers. So at 48 hours, you can see in blue this peak of virus production in a liquid interface culture, whereas in submerged culture, we have a quite inefficient production of the virus. And also when we looked at barrier integrity, basically in submerged culture, the cells are still happy, they are still there, they do not care about the virus. And instead, in a liquid interface culture, we have this breakdown of the barrier at 48 hours that also coincides with the high production of the virus. So this highlights the importance also of a liquid interface culture. But now this was quite an easy system that I showed you, but there we miss also some components that are present in the alveoli in the human. So the alveoli are not only consisting of epithelial cells, the 81 and 82 cells, but also of endothelial cells that are making the air-blood barrier. And also we have immune cells in the alveoli to clear infection. So this can be better modeled in an organ-on-chip system. And I'm using the system from Alveolix, which is this is the AX12 plate that I'm working with. So you can see this is a 96-well plate-like format. And one unit consists basically of 3 wells, but the cells are only seated in the central well, where we have a very thin membrane, where you can grow epithelial or endothelial cells on both sides of the membrane. So you get a very thin co-culture model. In addition, they incorporated stretch into the system. So by adding a microdiaphragm into their plate system, they can actually move the membrane and mimic the in vivo-like breathing motion. To handle this chip or to access the chip for experiments or to create the breathing function, you need 3 modules. Basically, you see the AX12 chip again that is on the docking station, and the docking station then connects the chip either to the breather, which is required to make the cells breathe, or to the exchanger to manipulate the cells or to do medium exchanges. So if you are also interested in more into the possibilities that you have with the system, you can also attend the talks of my colleagues from University of Bern and from Alveolix to present you some additional models. But here I will just introduce the COVID-19 model. And again, starting with the small array model, so with the callus-free cells, we have cultured them on the chip. And we also asked if the addition of the endothelial cells makes a difference for the infection of this cell type, of the callus-free cells. First, what we noted is actually that once we introduced endothelial cells in the system, the callus-free cells had enhanced barrier formation. So already after 3 days, we had really a tight barrier, which was significantly tighter than without the endothelial cells. However, upon addition of the SARS-CoV-2 virus, we saw that in both systems, we had efficient infection of the epithelial cells. So there were a lot of them positive for SARS-CoV-2 proteins. And we could also not detect infection in the endothelial cell layer, as you can see in the co-culture model. Also, we found efficient production of the virus in both systems, so in monoculture and in co-culture. And also we saw the breakdown of the barrier in both models. So we can see the infected cultures, the red bars have a breakdown of the TR, whereas it's still intact when the cells were not infected. So we also tried to translate this protocol to our alveolar model. As you can see here, first checking our immortalized alveolar epithelial cells in monoculture, we found that at low SARS-CoV-2 titers, we have a little reduction of the TR, but it is not very, very high. And also the virus production was very inefficient in this setting. Upon addition of the endothelial cells, instead we had a production of the virus that was increasing over time. Still, it is quite unproductive if you compare it to the inoculum, as you can see on the left bars, but we have an increase in the production of the virus over 48 hours. If we compare the efficiency of SARS-CoV-2 production between the monoculture and the co-culture, we actually see a significantly higher titer if the epithelial cells are in co-culture with endothelial cells. So this gives us at hand two models SARS-CoV-2, and also highlights the importance of choosing the correct setting and complexity of the model to achieve infection in these in vitro models that we have. To shortly summarize, so we have the model for the lower airways, the callus-free cells. They're very susceptible to the virus and produce high viral titers. And we also observed that the infection always results in breakdown of the barrier. But we saw that increasing the complexity of the model did not have a big influence on the infection dynamics. So basically, still we saw that a liquid interface promoted the expression of host factors in callus-free cells, but had little impact on the infection efficiency, as well as endothelial cells did not further enhance the infection in these model systems. Instead, in the alveolar setting, we were working with the immortalized alveolar epithelial cells. They express SARS-CoV-2 host factors, but they are unproductively infected in the monolayer cultures or in our model systems. However, upon increasing the complexity of the model, we were able to achieve better infection rates. So namely, we saw that in a liquid interface, it was crucial to be in or to infect the cells and observe the barrier breakdown, as we can also see it in patients. And also we saw that endothelial cells further enhanced the release and production of SARS-CoV-2 virus in the infected cultures. For future perspective, actually we plan now to characterize these models that we have now a bit better regarding their antiviral response and immune response, to evaluate if this is actually biologically relevant to what we see in the COVID-19 patients. And as a next step, we would also like to start developing a protocol for drug screening that we can actually apply this platform to screen for therapeutics for COVID-19. And with this, I would like to thank my colleagues from University of Bern and for Alveolix that made this project possible. And thank you for your attention.